Hi everyone, my name is Basala and I am from Satmia. So today we have Dr. Herman Chua with us, and today's session is sponsored by CSAPHN. And we'll start with the acknowledgements of the country, if that's possible. Thank you, Herman. So we would like to acknowledge the Aboriginal and Torres Strait Islanders, the traditional owners of this country. We pay tribute to their physical and spiritual connection to the land, waters, and communities. Enduring now as it has been throughout time, we pay respects to them, their culture, and to elders, past, present, and emerging. And I'll hand it over to you, Dr. Herman Chua. Thank you.
Thank you, Basala. Well, welcome everyone. Thank you for sacrificing your evening to learn about ECG. Essentially, let me just introduce myself. I'm Dr. Herman Chua, and I'm an emergency physician. I work at Modbury Hospital as well as Gall Hospitals. ECG is basically, has been my passion for a long time, and I'm passionate about sharing knowledge about all aspects of ECG. And so today we're going to talk about basically ECG in the context of acute coronary syndrome. And we're going to go through lots and lots of cases essentially. But before that, I just thought that the best thing to do is actually just to lay down some foundation, some core concepts essentially. Okay, we're going to have opportunity afterwards to actually for all of you to actually ask questions as well. If you do have questions along the way, please actually put it down in the chat. Busala can actually try and collate these together, and we can try and sort of address these questions at the end as well, if that's possible. Okay. All right, so let's get started. So the format today is that I'm going to talk about some core concepts, things that people should actually know before they launch themselves into ECG interpretation, especially in the context of acute coronary syndrome. And then the second part of this covers a whole host of real life cases. Okay, all right, here we go. Okay, so this is an ECG definition that I think everyone is actually familiar with, right? And this definition has actually been around for a while. In fact, it hasn't actually changed at all. The last iteration was actually 2016, as you can see in my reference there. And everyone knows this, right? People who have worked in hospitals before or out in the community, in that this concept of STEMI, ST elevation myocardial infarction, is defined in an ECG by basically more than 1 millimeter ST elevation in all the leads except leads V2 and V3. And the reason why V2 and V3 is because normally in normal individuals, you can actually, in fact, it's normal to actually have a little bit of elevation, ST elevation in those sort of leads. In fact, men below the age of 40 can have up to 2.5 millimeter elevation in those sort of leads. So that's why they say, okay, 1 millimeter elevation in all leads except leads V2 and V3, you need a little bit more. And then this concept about a new left bundle branch block. Okay. The thing is this, right? This definition is slowly being, people are beginning to realize that it has got limitations. And I'll show you through all the some of these cases that we're going to go through that, this is just not sufficient. In fact, what people are trying to do with a definition such as this, in fact, this definition has been around since the Gusto trials, back in the 20th century, essentially. It's been there for a long time. Essentially, what people are trying to do is actually diagnose this, and this is an acute coronary occlusion. And the thing is that people used to think that ST elevation is a surrogate marker of acute coronary occlusion, because this is what we're trying to get at, right? Because this is the thing that will the cardiologists can fix, because they will actually bring patients to the cath lab and open up the artery, put a drug-eluting stent, etc., etc. But I'm going to show you that it's more than just the ST segment. It's more than just ST elevation. The whole idea is to actually diagnose acute coronary occlusion. But the thing is that ST segment is not a good surrogate marker. Okay. All right. I'll just show you a couple of cases. And this is actually, all these are real life ECGs, obviously, from real life patients. So this is a patient that's, presented to us with chest pain. So I just want, in fact, we're going to have a poll right now, right? Okay. Very simple. I want you to tell me, is this a STEMI or is this not a STEMI? Okay, so the poll, I'm just going to leave that that ECG there, okay? And I want people to actually just have a look at it, okay? And what we're going to do is that we're going to discuss about this at the end, okay? After I laid down all the foundations, okay? All right, have a go, all right? So half the people have had a go. What about the other half? So this is not a trick, yeah. I mean, this is just to lay it out there for. Yeah. Okay. I think just for the sake of time, I'm just gonna end the poll now. Yeah. Okay. So about half of you thought that it was STEMI, half of you thought that this is not a STEMI. Okay, interesting. All right, I'll let's just move on, and we'll discuss this. I'll come back to this ECG, I promise, at the end. Okay. All right, let's just move on there. So just trying to get the next screen. Sorry, hang on. Just yep. So just trying to get to the next screen. Okay. And I just need to exit this again because I just can't seem to get to my next screen. Okay, sorry about that, guys. Okay, this is the second ECG. Same thing again. So this is a patient who presents with chest pain as well to either your general practice or your local emergency department. And once again, the question I'm going to pose to you is this: is this a STEMI? So we're going to have the poll now as well. Okay, so so we're just trying to get a poll up, okay? So 5 concepts I want to share, okay? So the first concept is basically the concept of evolution, where there is actually a predictable sort of change, okay, to I guess the ECG morphology, all right? So basically, as I talked about, it actually goes from normal right till hyperacute T wave, to ST elevation, and then Q wave development, and then basically the T wave inversion or reperfusion T wave, and then recovery of T wave. Okay, so we talked about that already, right? And so we talk about the T wave being hyperacute, and this is the ECG that I was showing you. All right, so basically this is a hyperacute T wave that you can see in leads V2 and V3, right, and V4. Okay, so can people see that now? If people can't see, please, Busala, just warn me, okay? And basically, with treatment, the T wave has actually gone down. So V2 and V3 and V4 has actually gone down. Okay, so putting it side by side, you can actually see basically the T waves of hyperacute T wave here on the left, and basically the normal T wave just there. Okay, all right. So we talked about the ST segment already, where it's actually measured from the J point. And then this is the morphology, the slide on morphology that I want you to actually have a look at, right? So the normal T wave actually starts from the left here, where it's actually a gentle sort of upslope, all right, in a concave sort of shape, and then it actually just descends quite rapidly. Okay, so very, very asymmetrical. All right, and then it becomes sort of straightened. Okay, the straightening of the T wave. Okay, that adds bulk to it. Okay, and then it becomes convex, and then the ST segment elevates. Everyone recognizes D, but can you recognize B? Okay, so that's the main challenge. Okay, and so I think we're here where we talk about changes to the T wave, it becomes hyperacute, it becomes bulky. We talk about changes to the ST segment, where it actually elevates. And now, the change to QRS complex, because it does change the QRS complex as well. Okay, so what happens with QRS? The R wave diminishes, the S wave diminishes, and then the Q wave actually develops. Okay, so basically in this ECG, you can actually see the hyperacute T wave in V2, in V3, in V4, and in V5, believe it or not. Okay, why is V5 and probably V6 as well? Because look at the height of the T wave in comparison to the height of the QRS, right? Okay, and look at basically the height of the R wave in V3 disappeared, V4 disappeared, okay, and V5 as well. Okay, so sometimes you hear terms like poor R wave progression. Okay, this is actually what they mean. Okay, the S wave has also disappeared. Okay, so you need to actually have an S wave normally in V2 and V3, but that's disappeared as well. So diminution or disappearance of the R wave and the S wave is actually part of this evolution of acute coronary occlusion. Okay, so another example. This is basically this one everyone can recognize, right? There's actually ST elevation V1 and V2 and V3 and V4, and notice the hyperacute T waves that you can actually see right up to actually V5 as well, right? And you can actually see the S wave is as if it's just being dragged upwards, right? Okay, and see in leads V2 and leads V3. Okay, so so there are changes to the QRS complex, yeah. Okay, and this one is just to show you the Q waves actually develop as well. Okay, so basically in the inferior leads, you can see the Q waves in leads 3 and in leads AVF there. Okay, all right. So the thing is this, right? ECG changes of acute MI is not only confined to the ST segment, but we think it is only the ST segment because the name suggests that, right? ST segment myocardial, infarction. So the second concept is the concept of proportionality. Okay, I kind of alluded to this, right? Okay, in that the degree of ST elevation that you see is really proportional to the height of the QRS. Okay, so the thing is this: you may not see 1 millimeter of ST segment elevation if the QRS is actually really small, right? Because it's in proportion. But that's what the definition says. The definition says you need to have 1 millimeter, right? If it is 0.5, nah, that doesn't cut it, right? But it just doesn't make sense because pathology knows no millimeters, right? So basically, this is actually an example of an inferior OMI, but you can actually see the straightening of the ST segment in leads 3. And basically, you can see not a lot of elevation, maybe 0.5 millimeter of elevation in these inferior leads, but this is diagnostic of an inferior OMI, right? An inferior STEMI, if you like, okay? But except that it's not really a STEMI as yet, okay? So there's not a lot of ST elevation there, but it's still diagnostic of an OMI, all right? So the millimeter thing, okay, got to rethink that, okay? So ECG changes of acute MI is not dictated by millimeter criteria, right? Okay. So that's the second concept, proportionality, right? The third concept is basically the concept of dynamicity, okay? And so the thing is, well, not ECG, the process of coronary occlusion, the thrombus that occludes the coronary artery, is dynamic, all right? Because it lyses spontaneously, it reoccludes again. So there is actually a change and there is actually an evolving process, okay? And ECG is only a 10-second representation of what the myocardium, the heart is doing. If that's the only ECG that you do, then you're only getting 10 seconds worth of what the heart is actually doing, okay? And so, it's really important to actually, if you suspect that this is actually an ischemic process, that you actually need to do serial ECGs, okay? Because like I've shown you, it undergoes these progression or evolution, and you can actually detect that in the T waves, in the change in the ST segment, and basically change in the QRS as well, okay? As as it begins, as the thrombus lyses spontaneously or thrombose again. Okay, so serial ECG is important to differentiate between ACS versus non-ACS etiology, because generally speaking, non-ACS etiology that gives you ST segment elevation, for example, LVH, left bundle, etc. Generally, they don't evolve in that time span, in minutes, hours. Generally, they don't. Okay, and so important to do it. All right. So just show you an example, and basically this is a patient that we saw who's actually come in with 5 out of 10 chest pain, and this ECG was done at 8:37. Nothing much to see here. All right. If this is the only ECG that you do, you will miss this ECG that was done 1 hour later. Okay, and now it's clear that there's actually ST segment elevation, and in this case, a concave ST segment elevation in the inferior leads. Okay, and so yeah, serial ECG, absolutely important. Okay, all right. So the fourth one is basically the concept of reciprocal change. Okay, you may have heard of this before, right? So what is a reciprocal change? Basically, it is the flip side image, which is recorded directly opposite leads with ST elevation. Okay, so in simple terms, is basically the image that is opposite the leads with ST elevation. Okay, and when you see reciprocal change, it is actually very specific for acute coronary occlusion, essentially, okay? And often is associated with more extensive infarct. Let's show you some examples, right? So basically, when you look at this ECG, the thing that actually jumps out is basically these T wave inversion that you can, and ST segment depression that you can see in leads 3 and leads AVF, okay? And the reason why they are like that is because it's actually reciprocal to lead AVL and lead 1, okay? I'm not sure whether you're familiar with the axial system of these leads, right? These basically are all limb leads, right? These 6 leads here, lead 1, lead 2, lead 3, lead AVR, AVL, and AVF, they are all limb leads, okay? You have to know their position, right? Okay, so basically lead 1 and AVL is basically opposite lead 3 and AVF, okay? So they are actually reciprocal, they are opposite. Opposite meaning if there's ST elevation here in AVL, there is ST segment depression. If there's a big upright T wave, which there is in AVL, there's going to be an inverted big T wave in the opposite lead. Okay, and so this concept of reciprocal change is actually very important. We'll see that in some of our cases later. Okay, so just bear that in mind. Lastly, basically the concept of association. Okay, and so the thing is that I don't want you obviously to know about the names of coronary arteries, etc. But it's just useful to know a little bit about anatomy. In that there are certain infarcts that involve certain territories associated with some sort of territories. Okay, so what I mean by that is that if you, for example, have got an LAD that's actually occluded, okay, it may actually involve the lateral wall as well. For example, why? Because that's the diagonal artery that actually supplies the lateral wall. It may involve the septum as well. Why? Because there is actually a septal artery that actually supplies there as well. Okay, and the RCA, the right coronary artery, for example, is it causes an inferior infarct, okay, because it's got this PDA or posterior descending artery, okay, but it also causes right ventricular infarct, for example, via this marginal artery. So there are some associations with different regions of the infarct, okay. So basically, and when we talk about regions, we need to know which leads represent what region, right? So this is the hexaxial system that I was referring to earlier. So leads AVR, AVL, AVF, and then lead 1, lead 2, and lead 3. And so basically inferior leads are these guys down here, right? Lead 2, lead 3, and lead AVF, right? Okay, because they point downwards, right? Okay. The high lateral leads are these guys here in lead 1 and lead AVL, right? Okay. And then you've got the chest leads. The chest leads are the ones that come out of the page, all right? And these are designated as V1 to V6, right? Okay. And basically, leads, V2 right to V6 are basically designated sort of, anterior, right? Anterior leads, okay? So diagrammatically, an anterior infarct that involves the left ventricle would be that. And then there's the lateral infarct, which is basically represented by 1 and AVL, as well as V5 and V6. And then inferior, like I said, is represented by 2 and AVF and 3, okay? And then there is that posterior wall as well, which is basically the wall behind, okay, the heart, right? Which is not represented by any of these leads, okay? We'll talk about posterior in a minute, okay? That basically exists as well, okay? And obviously you've got a right ventricular infarct as well here, okay? And so what is associated with what? I've already said anterior, yep, you can get lateral, so they are friends, okay? Inferior, well, if you actually occlude, for example, the RCA, you can get a posterior infarct, which is basically behind the heart here, a right ventricular infarct, okay? And basically, you can actually get lateral infarct as well, because the RCA, especially if it's dominant, it actually goes all the way right across the lateral wall as well, okay? And then basically, if you have a lateral infarct that's actually caused by a circumflex occlusion, it can actually cause a posterior infarct at the same time. So these associations are useful, and I'll show you why when we look at the ECGs later on, okay? And so just a couple of examples to start us off. This is, easy to recognize, right? ST elevation myocardial infarction, which is involving leads V1 and V2 and V3 and all the way to V5, right? Okay. And so basically, this is an extensive anterior wall infarct, right? And let's look at leads 1 and AVL. There's actually ST elevation there as well, right? Okay. Not a lot, 0.5 millimeter. Okay. So the high lateral wall is actually involved as well, because I know they are actually friends, okay? Friends with anterior, okay? So this is anterolateral myocardial infarction, okay? And notice the reciprocal change that you see here in 3 and AVF, yeah? Reciprocal to what? Reciprocal to 1 and AVL, okay? And so, this is another example, and in this case, it's actually an inferior infarct. Remember, what are the inferior leads? They are leads 2, leads 3, and leads AVF, okay? And basically, massive elevation there, right? This is in excess of 7-8 millimeters, right? Okay, and notice that there is actually a reciprocal change in AVL, right? Okay, reciprocal to what? Reciprocal to this lead 3, okay? All right, But more than that, you actually have got lateral infarct as well. So what inferior, who are the friends of inferior? Lateral, right? Okay, so you've got lateral ST elevation in V5 and V6, in fact, all the way to V4 as well. Not just that, you actually have got ST depression in V1 and V2 and V3. And now this ST depression, which I'll go through in a minute, represents a posterior involvement, okay? So basically, you've got inferal, lateral, and posterior myocardial infarction here. They're all friends, okay? So they are associated, okay? And this one, another example of inferior, posterior in V2, in V3, and basically lateral in V5, okay? And basically, in this case, the patient actually presented with hypotension as well, and we suspected a right ventricular involvement. We did a right ventricular lead. Don't worry about this, okay, because I'll actually be going through the right ventricular leads, etc. afterwards as well. So we did a right ventricular lead. You can see ST elevation in the right ventricular leads of V4, V5, V6, and so you've got right ventricular infarct as well, okay? So associations, all right, are important. So basically, we talked about some general concepts, all right, before we launch into our cases. So the first concept we talked about is the concept of evolution, where there is a predictable sort of change, not just to the ST segment, but change to the T wave, change to the morphology of the ST segment, not just the millimeters of the ST segment, change to the QRS. So that's something important that's not highlighted by the current paradigm, this current paradigm of ST elevation myocardial infarction or STEMI paradigm, okay? The second concept is the concept of proportionality, where we talked about the fact that ST elevation that you see is in proportion to the height of the QRS. Okay, the third concept is the concept of dynamicity, where occlusion of the coronary artery undergoes spontaneous lysis and thrombosis, and therefore causes sort of changes in the ECG. All right, and so therefore the importance of doing serial ECGs. And then fourthly, we talk about the concept of reciprocal change. It just means change that is opposite the lead with ST elevation. And sometimes the lead with ST elevation is not as obvious, but the reciprocal leads are more obvious. And we will look at some examples of that. And lastly, the concept of association, where certain myocardial infarction in certain regions are associated with myocardial infarctions of certain regions. Okay, for example, anterolateral sort of myocardial infarct. Okay, so we'll go through some examples in a minute, but we just have a mini mental break here because I've been talking a lot. Any sort of quick questions that people want to sort of bring up before we go on to cases? Okay, if not, you can type your questions on the chat, I suppose, and I guess Busala will try and collate that, and we'll try and get to it. Okay. All right, so let's just launch into some cases, if that's okay. I'll leave some time at the end for people to actually try and ask questions and all. Okay, so we're gonna have polls here. Okay, all right. So let's have a go. All right. So this is case number one, right? Okay. So case number one is this, right? Is that by the way, these are all real cases that we saw, through our departments. And so this is a 51-year-old male who presents with 2 to 3 hours of retrosternal chest pain with a bunch of risk factors, right? So, good story. And this is the ECG, right? Okay, so just have a look at this ECG. And Busala, we're going to poll now, right? So.
Yes, that's correct. The poll's up. Okay,
so the question I want to ask is this: is this a normal ECG, or does this ECG show an anterior OMI, or does this ECG show an inferior OMI? Okay, I'm going to just flash the ECG before you again, right? Okay. I can't really see the poll result, to be honest.
Sorry, let me.
Hey. Oh.
All right, it's up now.
Okay. Okay. So okay, that's fine. We'll end the poll. So most of you actually think that this actually shows an anterior OMI, right? Okay. So I don't want to stuff this up again. What do I do? I just minimize it, right? Okay. So those of you actually answered anterior OMI, you are correct. Okay. Now, just in case I just keep talking without sharing the screen, are people seeing this? Yes, Busala?
Confirmed, yeah.
My screen, yep. So I'm with the ECG, right? Okay.
Yeah.
All right. So the thing is that that you actually see are basically these hyperacute T waves, right? Hyperacute T waves in leads V2, in leads V3, V4, and V5, right? And they're hyperacute. Why? Because it's bigger or in proportion in comparison with the QRS. Look at how tiny the QRS complex is in V2 and V3 and V4 and V5 and even V6, right? And the fact that it's hyperacute just means that it's actually big and bulky with a wide base, right? Why is it wide in base? Because the ST segment has straightened, so it increases the area under the curve, right? Okay, so it's symmetrical, right? Not like your normal asymmetrical sort of T wave, all right? So basically, this is actually an anterior, and not just. I mean, there is a little bit of ST segment elevation in V2, probably about 1.5 millimeters, but there is no other ST elevation anywhere else. Okay, so the QRS, just notice how small and how tiny the QRS is as well. Okay, so all this taken together, all the changes that I've iterated actually points towards an anterior OMI. Okay, all right, so good. And so basically, it's not the size that matters, it's the proportion. Okay, so notice the symmetrical bulky T waves. The R waves has just basically, well, disappeared essentially. Okay, all right. I mean, look at how well it's not non-existent in V4. Okay, you leave this long enough, this will become. This is probably a small Q wave beginning to develop already in leads V2. Okay, so that's that. Good. So that's anterior, right? All right. So the next one is a 52-year-old with type 2 diabetes who presents with chest heaviness. Okay. So once again, the poll is this, right? Let's put up the poll, Busala. So is this a normal ECG? Is this an anterior OMI, or is this an inferior OMI? Okay. Okay, half between people who actually say that this is anterior and inferior. Well, the answer is basically this is anterior, right? Why is okay? We'll stop the poll now. So it's between, it's half basically. People saying half saying it's anterior, half saying that it's inferior. What do you notice? Well, basically hyperacute T wave. Okay, in leads V1. In leads V2, especially in leads V2, look how much is actually towered over the QRS complex. In leads V3, look the fact that it's actually same size as the R wave, should actually worry you. Okay, so basically it's actually there's not a lot of ST elevation. There's hyperacute T wave, yes. Okay, The other thing that you actually notice is basically leads 3 and leads AVF. Maybe this is where it may actually lead people astray, right? People think, oh yeah, inferior changes here, right? But the thing is that the ST depression and the T wave inversion that you can actually see here, in fact, the T wave, there's a little bit of biphasic nature to it. There's a negative positive to it, right? So the thing that you see here in leads 3 and leads AVF is basically a reciprocal change. Reciprocal to what? Reciprocal to the change that you actually see in AVL plus or minus 1. But hang on, I don't see a lot in AVL, and you're probably right. And sometimes the reciprocal change actually is more prominent compared to the actual change itself in 1 and AVL. Okay, and so and this is significant. 3 and AVF, it's definitely an abnormality right there, right? I mean, this is not a normal ECG, as in not a normal lead 3, not a normal lead AVF, and so basically, it is not an inferior. It is a reflection of what's going on in the high lateral leads in 1 and AVL. So this is basically an extensive anterior myocardial infarction, right? Which did not demonstrate any evidence of ST elevation. Okay, so the paradigm of you need to have 1 millimeter in 2 contiguous leads, out the door. Out the door. By the way, all these cases I show you are all proven OMIs, i.e., they've been taken to the lab and they've got proven acute coronary occlusion. Okay, so this is an LAD occlusion. Okay. Okay, so the third case, sorry, not the third case. This is just highlighting what I just talked about. Okay, so basically the changes, the hyperacute changes in lead V1, V2, V3. All right, and the reciprocal change that you can actually see in lead 3 and lead AVF. All right. So basically, if you're not sure what you're looking at in leads V1, V2, V3, because you think to yourself, hang on, there's no ST elevation. Is this normal? Is this not normal? Well, look at other things that will help support your case for this being an occlusion myocardial infarction, okay? And in this case, it's basically the reciprocal change that you can see in the inferior leads, okay? Reciprocal to what? Reciprocal to 1 and AVL. Okay, which are basically lateral leads. Okay, and remember the lateral leads are associated with the anterior leads. Okay, all right. So these, when you actually see this, it's highly specific for occlusion myocardial infarction. Okay, and just to prove to you, this is the same patient 2 hours later. Now people can see, right? I mean, now you will call your code because there is ST elevation in V1, in V2, not so much in V3, right? But now the ST elevation has actually, it now exists in leads AVL and a little bit in lead V in 1 as well, just proving my point that the changes that you saw earlier in leads 2, 3, and AVF, those ST depression with a biphasic T wave, it's actually a reflection, a reciprocal reflection of the change that you see in 1 and AVL. Okay, so no one would miss this. I mean, everyone will call this. But my challenge to you is that, will you call it when it's at this stage? Will you recognize this when it's at this stage? All right. So remember, time is muscle, right? The earlier you initiate treatment, the earlier you initiate transfer, the earlier you actually get the arteries open, the outcome will be better. Okay. All right. So let's go to case number 3. So this is a 43-year-old female with acute chest pain that radiates up her neck. Okay. And so this is an ECG. And once again, Busala, we have the poll, please. Is this an inferior? Is this a lateral? Or is this a posterior OMI? Which one is it? Okay, so okay, so most people, okay, we'll end the poll there. So most people have actually said it's inferior. Okay, and you're correct. So it is also a lateral, and it is also a posterior. Okay, so all those three answers are actually correct. Okay, so let's talk about this, right? So I don't need to talk about the inferior because people recognize the inferior, right? Okay, so basically inferior, what leads are they? Leads 2, leads 3, and leads AVF, right? Okay, so easy to recognize, right? So, ST elevation in those leads. And how do I know they are real? Well, there is reciprocal change in AVL, all right? So reciprocal change in AVL in association with elevation in the inferior leads. Well, okay, bang, you got the diagnosis inferior there. But don't forget about the others as well. You see ST elevation in V4, V5, V6. This is representative of the lateral leads here, okay? So there is a lateral involvement as well. Remember, inferior and lateral, they're friends, okay? They're friends, okay? What other friends do they have? Well, what about this? What about ST depression that you can see in V1 and V2? What do they mean in the context of inferior myocardial infarction? This is posterior involvement, okay? This is posterior. You can think about it like that, okay? You don't have such thing as posterior leads normally, okay? In a 12-lead ECG, all right, V1 to V6 does not cover your posterior bits, okay? So they are leadless, as in they are not detectable. But when you have a posterior myocardial infarction, if you do a posterior lead, all right, there will be ST elevation there, right? But what is opposite? What is opposite posterior? Well, lead 1 and V2, all right? So if you've got elevation in the posterior lead, in the reciprocal leads, you will actually see depression. And these leads are leads V1 and V2, okay? Okay, can people hear me? Is my projection okay, Busala?
Yeah, I can hear you fine. I'm not sure about the other participants though.
Right. Okay. I've maximized all my volume. I'll try and talk louder, I suppose. Okay. Um, but yeah. So basically, these are all our friends. The associations I was talking about. Okay. So basically, the inferior, the lateral, as well as the posterior. Okay. So you are all right. Okay. So this is inferior, postural, lateral myocardial infarction. Okay, all right. So next case is a 55-year-old smoker with a one-day history of chest pain, and this is her ECG. All right. So is this an inferior? Or is this a normal variant ST elevation? So some people call this benign early repole, all right? Or is this a posterior OMI? Okay, so okay, so basically we've got a split, right? Okay, last bits. Okay, so about half of you think that it's inferior. Um, close to half thinking that it's a normal variant ST elevation, and some of you thought that it's posterior. So let's have a look at this, right? Okay, so the thing is that this is, let me just, this is an infero-posterior infarct, okay? So inferior, okay, let's have a look at this, right? There is actually ST elevation in lead 3 and lead AVF, okay? The ST elevation is not a lot, it's probably 1 millimeter, okay? 1 millimeter in leads 3 and AVF, okay? And the shape of the ST elevation is actually concave, all right? I know I did say earlier in the talk that the ST segment do straighten, all right? But sometimes it does not, All right, and that's the thing, right? I mean, if everything works in accordance, like clockwork and all, it'll be perfect, but it doesn't, unfortunately. Okay, things just don't, go as the rule, right? So there is still a concave ST elevation, right? So concave ST elevation can still represent an acute coronary occlusion. How do I know that, right? How do I know that? Number one, I guess the history. So the history, it being, middle-aged, female, smoker. I didn't give you the characteristic of chest pain. So the pretest probability is already there, right? But let's just talk about ECG because today's talk is about ECG. I mean, look at Leeds AVL, right? What do you see? You actually see ST segment depression with T wave inversion there, right? Okay. And is that normal? I mean, look at the depth of the T wave, as in, in comparison with the QRS. That's huge. That's big, and there's actually ST segment depression in Leeds 1 as well here. Okay, you don't see reciprocal changes in the other pathologies. Okay, you only see reciprocal change in occlusion myocardial infarction. Okay, so this is an occlusion myocardial infarction. So in this case, it's actually an inferior. Okay, it has not manifested in lead 2, but more so in leads 3 and AVF. Okay, and remember what I said about leads V2. Normally, in normal people, you actually have some degree of ST elevation, right? In normal people, right? Okay, in men up to 2.5 millimeters. In women, maybe 1.5 millimeters. If there is no ST elevation in V2 and there is no sort of, right bundle branch block, etc., if there is no ST elevation, and instead you see isoelectric or even depression, it's abnormal. Okay, in this case, there is actually the involvement of the posterior wall as well. Okay, very subtle. Okay, but definitely there is. Okay, because that's not normal. Okay, that's not normal. It's very flat. Okay, and you can see the segments are actually very flat throughout here as well. Okay, but if you don't get that, you should get this. Okay, the fact that it's actually an inferior. Okay, all right. So the concept of reciprocal change is really important, guys. You need to be looking at it. Okay, so that's the key there. Okay, the reciprocal change. In fact, people have actually done studies on this, right? In that almost all inferior OMIs, right, are accompanied by reciprocal change in AVL. So much so that if you do not see any reciprocal change in AVL, rethink your diagnosis. Is this truly an inferior OMI? Okay. There are always exceptions in medicine. Okay, there's never such thing as 100% in medicine. Okay, but think about that. Okay, so that's that. The next case is basically a 55-year-old male with chest pain that radiates to his jaw, associated shortness of breath, and diaphoresis. Right. First of all, what do you reckon about that story? Right. I mean, it's right. I mean, this is basically an ischemic sounding chest pain. People say if if the patient sweat, you should sweat, right? So what is this? Is this an inferior OMI? Is this a lateral OMI? Or is this a posterior OMI? Okay, so let's we can stop the poll there. So most of you think 80% of you think that it's actually inferior OMI. Some of you think it's lateral, some of you think it's posterior, and once again, all of you are correct. Okay, they're all friends. Okay, so the most obvious one, obviously, that most of you have picked up is actually the inferior change, right? Okay, so there is some ST elevation, probably 1 millimeter, with bulky hyperacute T wave, right? Okay, and so the diagnosis is clinched and inferior. Okay, yeah, I mean I apologize that you can't actually click all of them simultaneously, okay? But this is just for the purpose of this exercise. So basically, how do I know this is real? This ST elevation and this bulky T wave that I see, this straightening of the ST segment that I see in the inferior leads, how do I know they are real? Well, look at leads AVL. That's actually a reciprocal change to leads 3, right? Okay, and what do you reckon? I mean, look at how big and bulky the inverted T wave is in comparison or in proportion to the height of the QRS there, right? That's significant. That is a reciprocal change there, right? Reciprocal to what? Reciprocal to the inferior guys here, okay? As specifically in lead 3, okay? All right, next, you actually see the straightening of the ST segment in the lateral leads here as well, okay? They are not sort of big, huge T waves such that it towers over, the QRS, but it actually is quite symmetrical in shape, right? The T wave, all right? These ST segments are straightening, okay? So I think there is a little bit of lateral involvement there, okay? So if you don't pick this up, doesn't matter, never mind, you got one more chance. Look at this, look at V1, V2, and V3, right? What did I say about those leads, right? Should you actually be seeing ST depression in those leads normally? If there is no right bundle branch, for example, or any other depolarization abnormality? No, you should actually see some degree of ST elevation, if anything, right? The fact that you're actually seeing ST depression means that there is actually, in this context, posterior involvement. So there is actually a posterior wall MI as well, okay? Look at how big and tall this R wave is, right? In V2 and in V3, right? And the reason why it's big and tall is because if you actually flip them, because reciprocal, remember the fact that there is ST depression in V1 and V2 and V3 is because you're seeing reciprocal change. Reciprocal to what? Reciprocal to the posterior wall, right? Posterior wall is demonstrating ST elevation, but you're not doing that because 12 lead doesn't cover that, right? But what you're doing is V1 and V2 and V3. So you see ST depression. And if you flip this, all right, the R wave is actually a Q wave. So what you're saying is actually a Q wave there, all right, in V2 and V3. Okay, so the answer is all of you are correct, okay? So basically, just to highlight things, the inferior changes, you can see there, the reciprocal change in AVL, and basically the posterior wall change as demonstrated there as well, okay? So posterior MI. So how do you actually diagnose posterior MI? Well, like I said to you, they are friends with inferior and lateral, okay? So when you see, and often case, right, people do, don't look at it because they've already clinched the diagnosis, right? You look at the inferior leads, ST elevation there, bang, don't care. That's it, I've got it, okay? But what else do you look for in a posterior, right? Like I said to you, ST depression, especially in lead V1 to V3, it can extend to lead V4 as well. If you see ST depression in these leads, V1, V2, V3, plus or minus V4, okay, in a context of someone who presents with ischemic sounding symptoms, all right, think posterior, okay? The tall R wave that's actually visualized in V1, V2, V3, like I said, is actually Q wave if you actually turn it upside down, okay? You may or may not see that depending on when the patient presents and when this ECG is taken, all right? So, early on in the piece, you may not actually see, so to say, Q wave. So the R wave may appear as small or normal, okay? So that is not important in the criteria in terms of diagnosing posterior, but the ST depression, okay, that's important, okay? Because that's a reciprocal change, reciprocal to the posterior leads, okay? So in fact, I wanna show you that if you actually try and flip it upside down, V1 and V2 and V3, you will be able to diagnose posterior because it manifests as ST elevation, right? And the R wave, like I said, it's actually your Q wave, right? So if I show you this image on the right, you will be able to diagnose this, no problems at all, right? So posterior leads, well, some people do posterior leads, right? I mean, you don't necessarily need to, in every sort of inferior, in case of inferior, some people, get an inferior and, oh, I want a posterior leads, okay? If you see ST depression V1, V2, V3, I mean, bang, you've got your diagnosis, okay? But if you insist, okay, if you really need to do it, all right, you actually remove leads V4, V5, V6, and then you attach it to the back. Okay, where do you attach it? Well, the tip of the scapula, we call it V8, okay? And V7, V9 is just sort of, just beside them, okay? So if you actually do that, you may be able to see ST elevation. Okay, so in this case, in this patient, and the ECG that I've just shown you, we did a posterior lead, and voila, there is ST elevation in V7, V8, V9. But just be really careful, right? The posterior leads are actually quite far away from the heart. It's actually there is a lot of intervening air in the lungs. And so because of that, the complexes are quite small. And so you may not actually see a lot of ST elevation. If you see ST elevation, fantastic. You've got the diagnosis. But if you do not see ST elevation, if you do posterior leads, it does not mean that there is no posterior myocardial infarction, yeah? So just bear that in mind, okay? Just because of the reason I just said, okay? All right. I hope that is okay with people, right? So let's move on if you're still you're still with it. Okay, case number 6, right? So this is a 50-year-old male with burning chest pain and associated dizziness. Okay, this is his ECG. And once again, let's have the poll up, right? So what do you think this is? So is this an inferior? Is this an anterior? Or is this a right ventricular OMI? Okay. Wow, this is close. So you've got equal sort of response for all three, right? Inferior, anterior, and I'm glad you answered that way, because then it actually brings up a point of discussion, right? Let's end the poll now, Basal. So okay, so that's really good. So okay, let's see what this is, right? Okay. Okay, forget about this little blip here. I think there's a little bit of artifact in the beginning of the ECG. Okay, so that's not anything. But so what do you see? Well, you see ST elevation in lead 3, a little bit in lead 2, a little bit in AVF, and I'm thinking, okay, is this inferior? Well, look at AVL. Well, yeah, it is inferior, because there's actually reciprocal change in 1 in AVL, okay, manifested by ST depression with that sort of, big sort of inverted T wave. You can see that T wave inversion. So that's definitely an inferior there, right? But then there is actually ST elevation in V1 and V2 as well. And you kind of think, okay, hang on. V1 and V2, they are anterior leads. How can I have inferior and anterior? Because they're not friends. They're not even neighbors, okay? So how can I have anterior MI? How can I have an inferior MI? I mean, you can't occlude 2 coronary arteries simultaneously. I mean, you can. You're very unlucky, right? But so what is this? How do you explain this, right? So these are the abnormalities. Okay, so basically, the ones who answer anterior MI, I get where you're coming from. Okay, you look at these leads and you think, hang on, convex shape ST elevation, leads V1, V2, those are septal leads / anterior leads, definitely an anterior, right? Okay, but actually it's not. It's this is actually an inferior MI with a right ventricular involvement. Okay, so what is this? So right ventricular MI, right, is basically it's usually present or in association or friends, so to say, with inferiors. Okay, and they are caused by occlusion of the RCA. Okay, the right coronary. Okay, remember the right ventricle is supplied by the acute marginal artery. Okay, which is actually a branch of the RCA. Okay, and the thing is this. So why am I bothering about this? I mean, so long as I can diagnose an inferior, I should be okay, right? The thing is that when you get involvement of the right ventricle, there is actually a higher complication rate, higher mortality rate. And in fact, it actually causes hemodynamic instability in a proportion of patients. Okay, in fact, when patients actually come in with inferior OMI with hypotension, you begin to think, is this a right ventricular? Okay, and that's because the right ventricle is not working, so therefore, it compromises the preload. Okay, so the thing is, you have to remember is this: lead V1, it's actually a right ventricular lead. It's actually placed, on the right side of the sternum. Okay, and sometimes the involvement of right ventricular OMI can actually extend to V2, and I've seen it extend to V3 as well. Okay, right ventricle is actually an anterior structure. Remember that anatomically. Okay, so how do you diagnose right ventricular MI? Okay, the thing is, right ventricular MI usually is in association with inferior. So you diagnose an inferior. Okay, you diagnose an inferior. All right, but in addition to that, there is actually ST elevation in lead V1. Okay, if you need to do a right ventricular lead, okay, so you detach V4, V5, V6 on the left side of the precordium and attach it to the right side of the precordium. All right, and so therefore you do a proper right ventricular lead, you may see ST elevation there. Okay, so if you want to diagnose right ventricular MI that way, fantastic. Okay, so this is the diagram there. So instead of doing it on the left side of the precordium, you actually do it on the right side of the precordium, you may get elevation there. Okay, so in this case, in this particular patient, okay, we did it. Okay, so I just did V4, V5, V6, and there you go. You get the ST elevation there, confirming that the elevation I see in lead V1 and V2 in the original ECG, that's actually a right ventricular sort of infarct that I'm seeing. Okay, so this is an inferior myocardial infarction with right ventricular involvement. Okay, and the reason why we want to actually know about this and diagnose this is because, like I said to you, it represents an extensive infarct. Right ventricular infarct can only happen with a proximal RCA involvement. And so remember, the more proximal the occlusion is, the more extensive the infarct. The more extensive the infarct, the more complication there is. And so therefore, the more myocardium is in jeopardy. And so therefore, in terms of the criticality or the timing of your transfer, that's up there. Okay, so you need to recognize all that. Okay, so I know that's a lot. That's a earful from me already. We have another few cases, believe it or not. But I just want to have a bit of a mental break here. Okay, I know people have been going, going through these cases. So, any quick questions that you wanna ask or anything at this time? Okay, if not, we'll just keep going. So each of these ECG obviously has got a learning point, and I guess reinforcing all the concepts that we just talked about earlier as well, right? Okay, so let's just go on, right? Okay, so the next one is actually a 47-year-old with central chest pain, and she actually looks very unwell. Okay, I remember this patient vividly. Okay, she looks gray. She looks as if she's going to arrest. Okay. And this is the ECG. What do you think? Let's have the poll, Busala. Sorry. So, is this a normal ECG? Is this an anterior OMI? Is this an inferior OMI? Okay. All right. So let's stop the poll because most of you think this is an interior, right? Okay. So so that's good. Actually, that's good because why? Because you actually see that ST elevation in V1 and in V2. But then you begin to think there's, and a little bit in V3 as well, right? But then you sort of thought, begin to think to yourself, hang on, is this elevation a normal sort of variant? Remember what I said about, normal people having sort of some degree of ST elevation in those leads. So is this normal? Well, no. Why? Because look at other supportive evidence, right? So remember, the answer is not just ST elevation or no ST elevation, right? Because that's what the old paradigm tells us, right? Because you look at other things as well. Look at leads 2 and 3 and AVF. What do you reckon? Right? There's actually ST depression, right? ST depression in lead 2, lead 3, and lead AVF, with biphasic sort of T wave in lead in all those leads, right? A down-up sort of T wave, okay? Biphasic, a negative, positive type T wave, right? That's not normal, okay? Remember what I said? If you actually see ST depression in the context of someone who presents with possible ischemic sort of symptoms, the first question I want you to ask is this, right? Is it possible that the ST depression that I'm seeing is reciprocal to an elevation somewhere else that I'm not seeing? Okay, so in this case, where is 2, 3, and AVL reciprocal to? Which leads? Are we talking about leads 1 and AVL, right? Okay, but I'm not seeing anything there, okay? Well, probably it hasn't appeared just yet, okay? But what has appeared is basically those sort of reciprocal change, okay? So let's just see what happens next to this patient, right? So so the answer to this is actually an anterior, okay? But being supported by the fact that there is definitely reciprocal change in the inferior leads, okay? Remember, these inferior leads, they are not reciprocal to V1 and V2 and V3. You kind of reciprocal change across different planes. Remember, these leads, the limb leads, are different planes compared to the precordial leads. Precordial leads is just coming out of the chest, right? But they are reciprocal to 1 and AVL, which is the high lateral lead, okay? Which is basically associated or friends with the anterior as well, okay? So let's see what happens next, right? So this patient went into this, right? So went into basically runs, short runs of proximal VT, right? And now you can begin to see the elevation is a little bit more in V1 and V2, and you can actually see that hyperacute T wave right now in AVL, right? Okay, the QRS has actually diminished to a small sort of amplitude now, such that the T wave is towering over the QRS in AVL now, okay? And that supports what we thought initially, that the ST depression that you see in 3 and AVF and 2, they are reciprocal to the elevation that you did not see initially, okay, in 1 and AVL. But now you're beginning to see, okay? Now the ischemic VT is beginning to sort of come in, and eventually the patient went into VF, okay? And it's very unfortunate because this patient could not be resuscitated, okay? So it started from that ECG, all right? That seemingly benign looking ECG, not much going on, not much happening, to this, okay? All in a span of an hour plus, something like that, okay? All right, so ventricular arrhythmias are actually a common complication, okay? They are a common complication, and that's the reason why you actually need to diagnose these patients in the ED, especially with the extensive infarct, right? Because the more extensive the infarct, if it's an extensive anterior, or if it is an infrapostural lateral infarct with right ventricular involvement, those are extensive infarcts. Those are the infarcts that will give you all these arrhythmias, okay? So VT and VF is a common cause of death. They're basically due to electrical instability. They are different from the VT that you get, weeks and months down the track after you have an MI, okay? They are different etiology. This is basically due to electrical instability, okay? Because if you fix the MI, i.e. the occlusion, i.e. you open up the arteries, you will help this patient, okay? So that's the learning there, okay? All right. Case number 8, 60-year-old, shortness of breath and lethargy. And let's have the poll, Busella. What is this? So this, we know that there's an inferior there, okay? I'm going to give that to you, okay? There's an inferior, in fact, there's an infraposterior infarct there. So is this sinus? Is this complete heart block? Is this second-degree heart block? What is it? This is not a dysrhythmia session, okay? But I want to talk about this, especially in the context of an inferior. Okay, let's put it in, let's put it in. Okay. So okay, we'll just end it there. Thanks. So most of you actually thought that this is actually second degree heart block. Well, it's not. It's it's actually a complete heart block. Okay, so how did we end up there? So basically, what you can see here is basically number one, diagnose an inferior. I hope you can by now, right? Okay. So how do I diagnose that? Well, ST elevation, predominantly in 3 and AVF with hyperacute sort of T's. This is supported by the reciprocal change I see in lead 1 and lead AVL. So there's definitely an inferior. But what more? I can see a posterior as well. How do I know that? ST depression in V1, in V2, in V3, maximal in those leads, okay? All right, so there's definitely an infra-posterior infarct here. What about the rhythm? Okay, so first of all, let's look at, there are two rhythms here, okay? There is the ventricular rhythm, which is represented by the QRS, and there's the atrial rhythm, which is represented by the P wave that you can actually see here on the screen. Can people actually see my cursor as I kind of move it around and toggle it around? Busala, can you see that?
Yes, we can see your cursor.
Okay, great, excellent. So that will help a lot, I guess. So, okay, let's go to the ventricular rate first, right? The ventricular rate, well, the easy way, all right? I'll give you my cheat way, all right? If it is regular, all right, which this is, okay, the cheat way is to actually count the number of complexes 1, 2, 3, 4, 5, 6, 7, 8, and multiply that by 6, okay? So because this is a 10-second sort of ECG, right? Every ECG is 10 seconds. So you multiply that by 6, 8 times 6 is 48. So ventricular rate, 48 beats per minute, okay? Let's look at the atrial rate, right? Okay, so there's a P wave there, and there's a P wave there, and there's a P wave there, as well as there, okay? If you actually measure between the P waves, there are basically about 3 big squares. So that equates to about a rate of 100 beats a minute. So two different rates, right? Okay, you got a ventricular rate at 48 beats a minute. You got an atrial rate going at 100 beats a minute, okay? And the next question I want to ask is this atrial rhythm related at all to the ventricular rhythm? Okay, let's have a look, right? So basically, the P's are just marching along and just doing its own thing. In fact, there's actually a P hidden here in the T wave. Look at how tall this T wave is, a little bit different compared to that T wave, right? Okay, so if you actually use a caliper and you actually just mark out the way the P waves actually are marching through the ECG, okay, you will see that the P waves are doing its own independent thing. Okay, so can you see my cursor just moving along? In fact, there's a P wave hidden in the ST segment. Can you see that? Can you see that notch there? Yeah. Okay. So basically, they are unrelated. The P waves are unrelated to the QRS. The QRS are doing its own thing. The P waves are doing its own thing. Okay. So this is basically a third degree heart block or a complete heart block. Okay. So in fact, you actually see this quite commonly in inferiors. Okay. Why? Especially in inferiors that are actually caused by right coronary artery involvement. Okay, so this is actually a complete heart block. So how do you explain this? Well, the AV nodal branch, the branch of the artery that supplies the AV node, okay, comes from the right coronary artery. All right, if you actually occlude that, you can actually occlude the AV nodal branch and cause a complete heart block. You can cause a second degree heart block, you can cause a first degree heart block, you can cause a sinus bradycardia, you can cause all sorts of things, okay? But in this case, it is actually a complete heart block. It's actually quite common, guys. I'm sure some of you have seen this already, okay? But you fix the patient, i.e. open up the arteries, usually you fix the heart block, okay? And it may be that, in the ED, you may need to support the patient by, temporary pacing. But by and large, transfer this patient to a PCI center, open up the arteries, and usually that will actually fix it. Okay, so that's an inferior with a complete heart block. Okay, all right. So we're nearly there, guys. Okay, so next one is 78-year-old with chest heaviness that radiates to the left jaw, right? So very ischemic sounding, right? Nausea, shortness of breath. So what do you reckon? Let's have the poll. Thanks. So what is this? Hyperacute T in inferior leads, abnormal T wave in leads AVL, ST depression in V1 to V3. You know, guys, I think you should be expert by now. You know, you find that I just keep repeating themes, isn't it? Repeating concepts, because I just want to drum this into you, right? You'll be sick of me saying all these things, repeating this over and over and over again, right? I'm so sorry you cannot actually take more than one, okay? So just pick the best, what you think is the best. Okay, okay. All right, let's end it there. So basically, yeah, I mean, you've got response from all three categories, and you know you're not wrong at all, right? Okay, so basically, what is this? Basically, it is inferior. You can see the changes in inferior. How do I know that? Look at the T wave. The T wave, basically, they're straightening of the ST segment. It looks bulky. It's white base, right? It's white base, all right? And it looks hyperacute, okay? And how do I know this is real? Well, look at the reciprocal change in AVL. Okay, so those who take reciprocal change, yes, that's correct as well. Okay, what is more? Well, ST depression in V1, in V2, in V3, right? What does that represent in the context of an inferior? It's a posterior, right? Okay, so there you go, guys. You're experts now. Okay, so you know this. Okay, so they're friends. Good. Okay, so next one. This is a 22-year-old male who complains of sharp left-sided chest pain, right? So the poll is this. Sorry, the question is. Sorry, I need to have the question. The question is this an OMI? Yes or no? Show you the ECG again. That's the ECG. Let's have the poll. Is this an OMI? So is this, well, STEMI if you like, okay? Or occlusion myocardial infarction? Yes or no? Let's have the poll. Okay. That's okay. So it can be tricky, right? So the thing is that there are mimics of ST elevation, and that's why that concept and that paradigm of ST elevation is faulty. Because not all ST elevation represents acute coronary occlusion or myocardial infarction. Okay, there are causes of ST elevation that is not occlusion myocardial infarction. Okay, and this is one of them. Okay, so let's have a look at this ECG again, right? So what do you see here? You actually see ST elevation, which is concave, right? It's kind of like a cup, right? Just in leads in leads 1, in leads 2, in 3, in AVF, and you actually see it in V1, V2, V3, V4, V5, and V6. So it's quite extensive, yeah, in terms of the ST elevation, in terms of the involvement of the multiple sort of territories, right? So, and that's one. Number two, you actually look at the height, the QRS itself, right? Look at how tall the R waves are, right? With myocardial infarction, okay, one of the changes that I've already said or iterated to you is that there are changes in the QRS as well, right? Such that the R wave becomes smaller, the S wave becomes smaller. Don't see that here, okay? Don't see that here. And not just that, at the end of the QRS in lead V4, there is actually that little notch. That little notch is called a J wave, okay? Whenever you see a J wave in association with ST elevation, okay, very, very likely this is not OMI, okay? I'm not going to say 100%, okay? I'm not going to say 100% because there's nothing 100% in medicine, but whenever you actually see that notch, that J wave, okay, in association with ST elevation, which is concave, all right, most likely it is not OMI. Then you see PR segment elevation in AVR, and then PR segment depression in all the other leads, a bunch of other leads, okay? So this is basically pericarditis, okay? So what are the changes again? You get global ST elevation, you get no reciprocal change. No reciprocal change in AVL, all right? Despite the ST elevation that you see in 2, 3, and AVF, there's no reciprocal change at all in AVL, okay? The presence of J wave, like I said, okay? And basically the preservation of the height of the R wave, okay? So, you know, I'm not going to talk a lot more about the mimics, except to say that there are mimics out there. So therefore, you know, you need to hone your skill with regards to trying to recognize changes of OMI, because there are a lot of mimics, okay? So that's pericarditis, okay? All right, we are almost finishing, and I'll give you opportunities to actually, you know, ask questions, okay? All right, next one, 73-year-old acute severe chest pain. Once again, bunch of risk factors, right? And this is the ECG, right? Okay, what is it? Let's have the poll. Is this an OMI? Is this subendocardial myocardial ischemia? Is this normal? Okay, so, all right. Okay, so almost, yeah, we can end the poll. It's almost equal number OMI equal sort of submyocardial subendocardial myocardial ischemia. I know that, you know, in med school, you know, we're taught, oh, if you actually see a bunch of ST depression, there's no ST elevation anywhere. Oh, this could be ischemia, as in myocardial ischemia and all. Could be true, okay? In this case, remember what I actually said, if you see someone with ischemic sounding symptoms, and then ST depression, in this case, is actually in V2, in V3, and extending to V4 as well. There's no ST elevation anywhere, okay? So if you actually see that, what's the first question that you need to ask? The first question you need to ask is this: is it possible that the depression I'm seeing is reciprocal to an elevation somewhere else that I'm not actually seeing? Okay? So in this case, is it? Yeah, it is actually a posterior. Okay, but hang on. You said that posterior, you know, is usually, you know, befriending, or, you know, is associated with inferior. Yes, but there is also cases of isolated posterior. All right, and in this case, it's probably an isolated posterior. Okay, I mean, to me, the ST segment here is definitely not elevated. The T wave looks a little bit sort of you know, on its way. The segment seems to be straightening. And it's probably on its way to sort of, you know, being elevated and all, okay? And the AVL looks a little bit suspicious there as well, okay, in terms of it trying to sort of, you know, do that T-wave inversion, reciprocal sort of change thing. But the main thing that you see is basically V1, V2, V3, all right? And this is basically an isolated posterior, okay? Can be very tricky, guys, all right? No ST elevation anywhere, nothing, all right? But this is, so to say, a STEMI call out, all right? Because it's an acute coronary occlusion. Okay, so this is basically you know, something that we just need to recognize. Okay, most of the time we get away with not recognizing posterior. Why? Because we just recognize the inferior, right? We diagnose inferior, bang, we're done, right? But in this case, can't help you. Okay, so posterior isolated in about 5 to 10% of cases. Okay, and often people just diagnose it as non-STEMI, okay? Not true, okay? Because this is acute coronary occlusion, okay? This is an indication for reperfusion, all right? And so what's the key to diagnosis? Once again, iterating what we have just said, okay, earlier. The key is to recognize the reciprocal change in the anterior leads, V1, V2, V3, okay? Always think posterior when there's ST depression in V1 to V3, more than V4 to V6, in the context of someone who presents with ischemic symptoms. Okay, remember this diagram. Okay, so basically, if you actually flip it, all right, you will see ST elevation. All right, if I show you this image on the right, you will diagnose it, no problems. Okay, but can you diagnose it when it is actually like that in V1 and V2 and V3? Okay, All right, good. 47-year-old male, stuttering chest pain, currently pain-free. What is this? Normal ECG, Wellens or De Winter. You may not have heard of some of these terms before. Never mind, that's why you're here. Okay, so a lot of you think okay, yep, we can stop the poll. So a lot of you think this is normal, okay? This is actually Wellens, okay? Let's talk about Wellens. Some of you may have heard of this before, so you know what Wellens is, okay? The abnormality is basically in leads V3 and V4. Very subtle, right? And what is that abnormality? The abnormality is the biphasic T wave. Can you see the up-down T wave, the positive negative T wave in leads V3 and leads V4? All right? That's not normal. Okay, in the context of someone who presents with ischemic symptoms but now is pain-free, all right, this biphasic T wave is a representation of reperfusion. Okay, so let's talk about this, right? So, in fact, when you actually do an ECG an hour later, okay, you get more changes. Remember about dynamicity? There's always sort of change when the thrombus lies or occludes again, etc. In this case, the thrombus has lies and there is reperfusion. And what started off as just changes that you can see in V3 and V4 has now extended. All right, V2 now is biphasic. V3 now is not biphasic anymore. It's wholly inverted now. It's in fully inverted T wave in V3, fully inverted T wave in V4, but now V5 is beginning to be biphasic. V6 is beginning to be biphasic. Okay, so the development of Wellens waves there. Okay, what's Wellens? Wellens is a reperfusion syndrome. To explain it simply, it is a once occluded artery which has now opened up or reperfused spontaneously. Okay, in fact, you actually open up this artery in the lab, it will actually show these changes as well. Okay, except that we don't record the ECG, we don't see it. Okay, in this case, this is a patient who had an occluded artery. That's why he had stuttering chest pain, right? But when he presented to us, his chest pain has resolved. Okay, meaning his thrombus has lysed or there's spontaneous reperfusion now, and now he's pain-free. All right. Wellens can only be seen, those waves that I showed you can only be seen in a pain-free state because it's a reperfusion state. Okay, so if you want to think of it another way, it's an aborted MI, in an MI that did not happen, but can happen again anytime because it can reocclude again. I hope that makes sense to you, okay? So it's a syndrome. Syndrome means that you need to have a clinical component and you need to have an ECG component. What is that clinical component? The clinical component is an ischemic chest pain that has now resolved. That is the clinical component. What is the ECG component? The ECG component is the biphasic or the inverted T wave that you see, okay? So they need to have a history of angina equivalent or chest pain. They need to have that pain resolved by the time the ECG is taken. All right. And if you do troponin, it may be normal, but now in the age of high sensitivity troponin, you may see a bit of elevation. There are two types of Wellens waves, right? Pattern A, which is the biphasic wave that you can see here in V3. All right. And pattern B, which is a fully inverted T wave that you can actually see as represented in V3. Sorry, biphasic in V2 and fully inverted in V3. Okay, and the rule is this: pattern A always evolves into pattern B if you leave it. If the patient remains pain-free and if you repeat the ECG again, all right, which I always ask people to do because if you don't see this, okay, you don't see the dynamicity, all right, is that pattern A always evolves into pattern B, which is what exactly we saw in our patient, right? Okay, so, and what more? The R wave is preserved, okay? So there is R wave, so it hasn't infarcted, okay? Hasn't infarcted yet, okay? No pathologic Q wave, R wave is still okay, and it's always in a symptom-free or pain-free sort of state, okay? All right? So that's Wellens. You can see Wellens not just over anterior leads, you can actually see it over any leads, okay? Inferior leads, etc. as well, okay? So that's that. Okay. So this is our second last case. 60-year-old, central chest pain that radiates down the left arm and not relieved with GTN. What do you see here? That's at the pole up. So is this an anterior OMI? Is this a right ventricular OMI? Is this an inferior OMI? Okay, so anterior OMI and right ventricular OMI going neck on neck. Okay, all right, we can end the poll there. All right, so what is this, right? What is this? And I can understand why you actually put those two, right? So okay, what do I see? The thing that strikes me as I actually look at this straight away, right? Number one, this is a good story. This is a good ischemic story, right? Okay, so pretest probability is high already. Okay, so and then you look at this. Okay, so V1, there's actually a lot of ST elevation there, right? A lot of ST elevation. The current STEMI paradigm says you need to have ST elevation, not just like 1 millimeter, but you need to have it at two contiguous leads, okay? No, it's not present in V2 or V3 or anything like that, okay? It's only in one lead, actually. So it doesn't really fulfill that sort of criteria, but there is a lot of ST elevation there. But what else do I see? I actually see this Wellens waves, right? In lead 3 and lead AVF, where it's actually down up, positive, negative, right? It's a biphasic sort of T wave, right? Okay, right? So, there is a component. I know I said that the patient still has chest pain, but there is actually the demonstration that there is something going on in the inferior here as well. Look at how saggy the ST segment is in this AVL as well. So I think there's actually reciprocal change as well, okay? So in the context of what we talked about, right? ST elevation in V1 in the context of inferior change, what is it again? A right ventricular. Okay, so this is actually a right ventricular. Okay, so you got this change in the inferior as well as this change in lead V1. Remember, V1 is a right ventricular lead. Okay, all right, despite the fact that it's advertised as an anterior lead. Okay, so it just if you try and use code STEMI call out criteria that I just showed you, just doesn't fit it, does it? It just doesn't fit at all, right? So right ventricular OMI, what is it? It's sometimes also called pseudo anterior, and you can see why, right? You can see why, because ST elevation lead V1 and sometimes lead V2. Oh yeah, that's an anterior. It's not an anterior. It's a right ventricular. Okay. V1 is a right-sided lead. Okay. Remember, when there are inferior sort of changes, i.e. inferior OMI, all right, and when you see ST elevation in V1 and V2, think right ventricular, okay? And that's important because your treatment is actually a bit different, right? Because your preload is compromised, you want to support and maintain your preload, right? So you actually make sure that you've actually got fluids going for this patient. You avoid GTN to actually, in order not to exacerbate the hemodynamics or cause hypotension, okay? All right. Nearly there, guys. Last case now. Okay. So I'll end with this one because this is something that is just brings everything together. Okay. So what is this? This is actually someone, a 57-year-old obese man, burning chest pain, background of hypertension and diabetes, and the first troponin that you got back normal. Okay. And this is his ECG. What do you reckon? Okay, so the choices I gave there is this Wellens? Is this De Winter? Is this normal? Okay. Okay, so a lot of you got it correct, and yeah, because we have already talked about Wellens, right? And you know that this is not normal, so by elimination, it has to be De Winters, right? Okay, so what is De Winters? Right? Okay, we'll end the poll there. Thanks. Cheers. So basically, what's the abnormality, right? The abnormality is the hyperacute T wave that you can actually see in V2, V3, V4, V5, and probably the beginnings of V6 as well. Okay. And look at how big and how tall and how bulky the T wave is in comparison with the QRS, right? Not just that, there is no ST elevation, guys. Okay. Remember, I showed you some ECGs earlier with hyperacute T wave with ST elevation. Now, this is special. This hyperacute T wave has got ST depression. Look at V3. Look at V3. There's upsloping ST depression there. Look at V4. There's upsloping ST depression, okay? How do I know? Because the J point ends just about there where my arrow is, all right? So there's upsloping ST depression. The J point ends just about there, okay? And so there's ST depression. This isoelectric, there's no ST depression here, that's isoelectric there, okay? And also there is some evidence of reciprocal change there in 3 and AVF as well, okay? So what is this De Winter all about? De Winter obviously is about, is after this Dutch cardiologist, right? In fact, you know, him and Hein Wellens, actually, they are from the same sort of cardiology sort of setup. So basically, what is De Winter? It is a hyperacute, tall, symmetric, upright T wave that is preceded by upsloping ST depression. Okay, and this is special because when De Winter first described this, all right, this pattern is static, meaning that there is no ST elevation and it does not evolve to become ST elevation, all right? Despite that, there is acute coronary occlusion because these patients get taken to the lab and there's proven to be, you know, LAD occlusion, okay? And they never manifested any ST elevation, okay? In fact, they actually manifested ST depression in association with the hyperacute T wave, okay? And so, and also to support that, there is also the reciprocal change in 3 and AVF, okay? And sometimes you can actually see ST elevation in AVR as well, okay? But the main thing is those hyperacute in waves that you actually see in the anterior leads, okay? So originally, like I said, it is described as a very static pattern, but ever since then, all right, it's actually been observed also as a temporary phenomenon. Definitely, I've seen this in the context of, so you do it right now, it's De Winter's, and then you repeat it in 15 minutes, half an hour, oh, suddenly the segments elevate, okay? So I've seen both of them, okay? But you need to recognize this because if it presents with just that hyperacute with that ST depression, that is a criteria for call-up. That is a criteria for you picking up the phone and calling your cardiologist and transferring your patient, etc. All right, no ST elevation, guys. All right, but that is a sign of acute coronary occlusion. Okay, and you know, I would hope that most cardiologists will actually know about De Winter's, okay? But you know, given the story and everything, you know, hopefully, you know, you should face no resistance there, okay? So look, I mean, obviously, there's a lot to cover, and I've covered a lot today. And the thing is that there's still a lot more to, you know, learn and all. And look, you know, I'm happy for you to ask any questions, or if you have any queries that you know, that you may have, you know, happy to actually do that. While you're constructing your question, let me just go back to the first couple of ECGs that I showed you. I don't know whether you remember that, okay? All right, because we're going to end here, but you keep asking your question and I'll try and answer them, okay? So the first ECG I showed you is this. And the question I ask you is this a STEMI? Yes or no, right? Okay. If this patient presents with ischemic sounding chest pain, right? So there's no ST elevation, right? But what do you see? You actually see symmetric, bulky, broad-based, hyperacute T wave in these bunch of leads, V2, V3, V4, V5, and V6, all right? And no ST elevation, guys, no ST elevation, okay? This is actually diagnostic of acute anterior MI, okay? and I know it's scary, right? I mean, you look at this, and how many of you will actually pick that? This patient actually ended up having a mid LAD occlusion. Okay, and then the second ECG I actually showed you is actually this. Is that so? Is this a STEMI or is this not a STEMI? Right? Okay. Once again, no ST elevation anywhere. Okay, but what actually stands out, right? Look at this ST depression that you can see here, right? The down up sort of T wave, the biphasic T wave, the down up. Wellens is opposite, right? Wellens is up down, right? If you see a down up, it's a reciprocal change, all right? In 1 and AVL. Reciprocal to what? Reciprocal to these guys here in 2, 3 and AVF. There is no ST elevation, but the segments are straight, all right? The T waves are bulky. It's symmetric. In fact, Q waves are beginning to develop here in 3 as well, okay? In fact, just this is also a patient that was taken to the lab, okay? Because we called this, and this patient had a proximal RCA. In fact, just to let you know, the computer read of this particular ECG says normal sinus rhythm, normal ECG. Just to tell you that don't trust the computer, okay? You need to be that expert, all right? Not your computer system, all right? You need to be interpreting that ECG, all right? So it's not easy, all these things, okay? But the thing is this, right? The more you look at it, right, the more familiar you are. Someone actually once said that looking at ECG is like looking at faces, right? You look at a face and you recognize that someone, right? It's same like an ECG, right? The more you look at it, right, the more you recognize, aha, that's a hyperacute bulky T wave there, okay? I see that because I see a lot of normals, and that's not normal. That's hyperacute. The reason why it's hyperacute is this, and this, and this. Okay, I hope that makes sense to people. And if you learn one thing or two things, fantastic. From tonight, I realize I've shared a lot. I've talked a lot. If people have any questions, feel free to actually ask. I'm happy to take any questions. And look, if people are afraid to ask here, look, you can actually shoot some questions to Satmir and I'll get the question. I'll try to answer them as well. But if people have got questions here, I'm happy to answer them. Okay, no problems at all. Good resource for ECGs. Look, a lot of resources out there. Okay, look, to start off with, right? Okay, let me just unshare my page and then I'll just goodness. Okay, can't do this. But one of the if people are very, very, I guess, in the beginner's realm, I suppose, of ECG, you obviously want to know what's normal first, right? Okay. So the ECG Made Easy series by John Hampton, that's actually a good start. For emergency medicine, there is actually this textbook, which is actually electrocardiography in emergency medicine by Amal Matu. That's actually a good text as well. If people want to get hold of that, okay. There are dozens and dozens of others, okay. But really, I think to start off with, that's actually good. There are actually blogs out there as well, which is actually good ECG sites as well. I'm sure you've come across that as well. Troponin rise, right? I tell you what, if you are the person who relies on troponin, right, you'll miss a substantial proportion of these changes that I showed you, okay? And the reason is because it takes time for troponin leak to happen. I know we're in the age of high sense troponin, and they can actually pick things up really, really quick. But as I showed you, some of these are accompanied by absolutely normal troponin, their first troponin, okay? And if you were to wait, time is muscle, guys, okay? So I still think that that's not the answer. It is part of the answer, as in part of the big picture, but you need to be basically interpreting your ECG as well, okay? So you need to be doing that. So any other questions before we end the session? Like I said, if people are think of any questions that you want to ask, or something sort of came up, or even if you want to shoot me an ECG, right, which a lot of people do, I'm happy to actually do that. But I'm not I'm not going to interpret it for you from a medical legal perspective, as in, oh, this is I'm just going to offer you an opinion. That's all. Okay. So yeah, if nothing else, I want to thank everyone. Thanks, Samir, for organizing the session. I hope you found it useful. We do run sort of face-to-face sessions as well, and sometimes face-to-face is a little bit better as well, because then I can actually see you can see me. We use the whiteboard and I can illustrate things and things like that, and there are sessions out there, and you can actually log on to Setmir to actually find that out as well. So yeah, thank you everyone, and have a good evening.
Thank you, Herman, and thank you everybody for coming. And I apologize if there was any technical difficulties that we had today. There is a question from George, I think. Can you arrange a session for arrhythmia now?
Yep.
So
Certainly with due time. Yeah. I mean, arrhythmia is such a big sort of area, isn't it? Yeah. I mean, I can talk all day about it, but yeah, sure, for sure. I mean, we can actually go through the common dysrhythmias if you like, yeah, the common dysrhythmias, and yeah, certainly we can try and see whether we can tee that up, organize it, sometime in the future.
Yep. And another question as well. So
Yep.
it says here, so if there is an ST elevation, can this still be used as diagnostic? I'm not quite sure how to pronounce that, but it's via Cheria.
Sorry, if there is ST elevation, can this still be used as diagnostic criteria? Oh no, don't get me wrong. If you see ST elevation as in the current paradigm, I mean that is diagnostic, right? That is diagnostic. So don't get me wrong. But what I'm saying is this, right? It is more than ST elevation, right? If you wait for that ST elevation, and I've shown you several cases. Those last two cases is a prime example, right? If you just wait for the ST elevation, you will miss a substantial proportion, right? That is the point, okay? So no, definitely, if you see that ST elevation, please call it. All right, I'm not dismissing the previous paradigm. Okay, I'm just saying that there's more to the previous paradigm. Okay, that's what I'm saying. I hope that makes sense. Yeah.
Great. And
Thank you, everyone.
Questions. So thank you everybody for attending. And this session will be recorded as well. So hopefully it will be uploaded by the end of this week, and you should be able to see the slides and also Herman's lecture as well. Perfect. Thank you. Have a lovely night, and thank you, Herman, as well.
Thank you.
Great effort to all. Yeah, thank you.
Yes.